we are here at the ACCRF patient gathering, and I am incredibly pleased to introduce you all to Dr. Wayne Hofstetter, who is a professor in the Department of Thoracic and Cardiovascular Surgery at the MD Anderson Cancer Center in Houston. This is an incredibly, topical subject for ACC patients. We know that about half of ACC patients eventually develop distant metastases, usually to the lung. And certainly a major issue is how to deal with those lung mets. And there really is not a very well-defined standard of care, what to do. We know that some patients will have radiation or ablation or surgery or systemic therapy to deal with these lung mets. But one thing that, we know is that surgery is often one of the main ways of dealing with lung mets. And we thought it would be incredibly important for patients to hear from a clinician who is very experienced with this topic and to ask him questions about it. But before we get to that, I just want to hand it over to Dr. Hofstetter and thank you so much for joining us today and educating us.
Terrific. Well, congratulations on having a great meeting, and I'm happy to be here. As Jeff said, I am a thoracic surgeon, so I have the occasion of taking care of patients with adenoid cystic carcinoma, both from a primary standpoint because they grow within the lung or the airway, and also because they can become metastatic in the lungs. And probably one of the more frequent operations that we do at a cancer center is to take care of lung metastases by removing them surgically. So as advertised, I'm going to talk about how and why we would remove lesions from the lung when it's associated with metastatic adenoid cystic carcinoma. So one disclosure is that I am running a registry trial here at MD Anderson, where we are experimenting using ablation rather than surgical procedures. And ablation, which I can describe, involves either using heat or cold to destroy tissue. This is a catheter-based therapy in which we place a needle into a lesion and can destroy it while it's still in situ. It is experimental, and that's why it's on study. So lung metastasectomy, it's the surgical removal of lung masses that have arrived via hematogenous spread, meaning that the tumor started somewhere else in the body as a primary, but then via translocation into the bloodstream, wind up in the lung and then continue to grow there. I'm going to apologize for being outside. I just finished an operation, so you're going to hear some background noise. So if it gets to be a little bit too distracting, let me know. The data that we have on this is all retrospective. The procedure for removing lung nodules, even when the tumor is started elsewhere in the body, goes back many, many decades. But because the experiences are all differentiated between histology, meaning most of these are done for colorectal carcinoma, sarcoma, melanoma, renal cell carcinoma, even lung cancer itself, we don't have a very good way of performing randomized trials to delineate whether one type of therapy over another is better or not. So because it seems to be a reasonable alternative and it gives patients the option of having their tumors removed and potentially coming off of therapy, we have done this for the number of decades. It's controversial as to the benefit in terms of overall survival. There are several studies showing that the natural history of ACC is not affected by us performing metastasectomies or lung removals, and that there's no change in the overall survival compared to best supportive care. I would argue that that has a lot to do with the selection criteria of who you take to the operating room versus who you don't take to the operating room. As I said, there's a history of resection of lung mets for many other tumor types, and it remains one of the most frequent operations that we do here at MD Anderson. Now, what are the advantages of adenoid cystic carcinoma over other types of carcinoma? ACCs have a slow growth rate. Now, you'll note either from your own experience or from people who have talked to you in the past, they say, well, how long has this been in my body? A typical tumor has to go through 30 doubling times to arrive at 1 centimeter. In other words, before you can even detect it on x-rays, it has to have doubled about 30 times. ACC has a doubling time of upwards of about 300 plus or minus days. So you can imagine it takes many, many months, if not years, to get to the point where it's a centimeter. So it's a relatively slow growing tumor. If you compare that to lung cancer or other typical types of carcinomas that I take care of, they have a doubling time of about 30 to 60 days. So you'll recognize in the survival curves that I'm going to show you later is that rather than looking at survival curves that are at 5 months versus 10 months, you're looking at survival curves that are 50 months versus 100 months. So this is a relatively slow growing tumor. And I think that's one of the large reasons why when people say we don't see a difference in overall survival with or without metastasectomy, it's because we're dealing with such a long time horizon, fortunately. The tumors are also radiation sensitive. So it is correlative to tumor size, but smaller tumors and areas where we have micro residual margins, or what we call microscopic disease, those tumors are sensitive to radiation, and radiation can be a good adjunct. The other frequent occurrence and advantage of ACC is it occurs in younger patients. I operated on a 30-year-old today who I just finished operating on for an ACC. I operated on a 30-year-old on Friday for an ACC, and typically my patient population tends to be in the younger age bracket. So you have the advantage of being able to recover rapidly. Now, just in terms of giving some examples, this is a patient I operated on in 2012, and it may be difficult for you to recognize normal anatomy versus abnormal anatomy, but you should be seeing his main airway coming down here from the trachea into the right and left mainstem bronchi as we go into the right lung and left lung. But what you're seeing here, and if anybody can give me a nod that you're seeing it, Jeff, put your head in the screen and say, yes, I'm seeing it, is that there's a tumor sitting in the main airway, extending down into what we call the carina or bifurcation. It's a relatively large tumor, and they require surgical resection because they are not amenable to other types of resection. So what we did in this patient situation back in 2012 was to take him to surgery. We resected the main portion of his airway, and we reconstructed the airway by saving all of the lung, not removing either the left or right lung, but removing just airway, reconstructing the airway, and putting, all the parts back together again. He had, at the time, microscopic margins that were positive. We knew that at the time of surgery, because as we were cutting, it was showing tumor left behind. So we had to give him radiation afterwards. Lo and behold, we followed him. Here, this is another example of how we do these airway resections. This is something like what I did today. I removed everything and put it back together. This is what I did on the patient I showed you from 2012. So 8 years later, we had been following this gentleman. He was in his 40s when I initially operated on him. And he was at the point of telling me, well, I'm kind of sick of coming to see you. You keep telling me there's nothing going on. I said, well, we're still watching some little things in your lungs, but the evolution is so slow. I don't know what's going on. We had started watching a lower lobe lesion on the left lung in about 2017, and it had been very slowly growing. But you'll notice that the lesion that's right here, and this is a metastasis from his adenoid cystic carcinoma, was starting to push up against the edge of the lung. And those are the ones that I start to worry about. And I'll show you why in a second in a different example. But the lesion is small. It's easy to resect because it's not going to require taking much lung out to take out. But it's pushing up against the edge. We had a conversation about surgery. He's asking, well, is this tumor going to do any damage to me? I said, well, over a period of time, it may jump out of the lung and get into the pleural space, into the cavity of your chest, and become unresectable and potentially incurable. So as long as it's contained in the lung and it would be an easy operation, we should probably think about taking care of it. So we did, and he did well from that operation. But over the subsequent 3 years, we started following as well. And then right next to where we operated, you see this small little lump. And if I go back and look at its old films, back to 2020, it was probably a tiny speck then that we didn't see or be able to feel during the operation we did as a minimally invasive operation in 2020, but it started growing. Again, same risk of this tumor coming through the edge of the lung. So I said, we need to take you to surgery. So we took him to surgery to take this thing out, and then realized that at the time of surgery, this thing that we thought was heart was actually tumor as well, growing into the back of the heart. When we go back to 2017, we recognize here's this tiny little wisp of something, looks like radiation change. And here's what looks like to be a coronary artery that's probably the tiny beginnings of this ACC. So he's going to get radiation, and I'm sure he'll do well with that because the area was not resectable. But my point being in showing you this is that these tumors begin, they grow slowly, 6 or 7 years it takes to grow up to the point where they are at a point where we think about we should resect them. But they're difficult to delineate. We have to start looking for small things and what things are at risk and what things can potentially be risky for you later on. Another example of a patient who was originally resected in 2013. And then she came to see me with this nodule. She had been followed for a little bit of a time with this nodule growing. She had another nodule that was a little bit higher up. And we had the same conversation. I said, these are easy to resect. She had had a nodule resected from the right lung several years before. 3 years later, she had nodules growing in the right lung. She had talked about potential options. And I said, well, from the standpoint of treatment, if we resect these things, it will potentially prevent them from bursting or perforating through the lung and winding up spreading tumor inside the inside of the chest. And I told her it is possible because the tumor is already up against the edge of the lung that could have occurred. Now, removing tumors like that in a metastasectomy, we can do with a robotic, minimally invasive operation that's quite quick. The operation takes about 30 to 40 minutes. The recovery time in the hospital is typically 1 day. So we talked to her about options for local therapy. Surgery, we can do this as a minimally invasive video-assisted thoracoscopic surgery. We can do it robotically. We can do it open if there's too many metastases to take care of minimally invasive, or if they're very deep, we want to go in and actually be able to put our hands on the lung and feel them and take it out. If the patient is not a surgical candidate or does not want surgery but does want treatment, we can consider radiation with stereotactic radiation. And then I mentioned to you ablation, which is either microwave ablation or cryo, which is a reasonable alternative, but something that is evolving. What's the data on this? Well, some data exists and most of it's retrospective, but there are multiple approaches to the management of metastatic adenoid cystic carcinoma. When it's widespread through the body, it's not something the surgeon can take care of. Also, when it's very, very tiny, it's not hurting a patient. And so we say, let it evolve. It's not hurting you. You don't need to undergo the risk of surgery until it starts to appear to start growing into something peripherally or look like it's getting out of control. This is a potential algorithm that was offered in this paper. It's one that I think is pretty typical of how we manage therapy. So if the metastasis is amenable to local therapy, meaning if we could go in there and resect it like the pictures I showed you before, we would consider going in to do surgery or radiation. Those tumors that are on the outside or edge of the lung are sometimes more difficult to radiate because they're up against the chest wall and harder to reach, and are a really good option for surgery. If they're not amenable to local therapy, they go in to look at either surveillance or cytotoxic therapies or drug trials. Now, just because there's something growing in the lung doesn't mean that we want to operate on every single lesion growing. They evolve over a period of time. Sometimes these things are so small that they're difficult to find. So we really don't advocate taking patients to surgery for metastatic ACC unless the tumor is threatening another organ, such as the heart, like I showed you, or it's threatening to perforate through the lung, or it's grown up enough that we can see it. So in this situation, because the tumor is up against the wall, it looks like it had the ability to perforate through the lung, I was really advocating for surgery. Is it worth it to do surgery? Well, this guy, Ugo Pastorini, he's been doing metastasectomies for about 40 years. He started the International Metastasectomy Group and has written a paper on just about every histology. He started writing on colorectal carcinoma, sarcomas, et cetera, and has written a paper on just about every different cancer type that he's removed from the lung. In this situation, he wanted to talk about adenoid cystic carcinoma. And when you compare patients who had surgery versus those who didn't, there are certain prognostic features that improve the overall outcome or survival. People who have had a disease-free interval, meaning that their original tumor was resected more than 3 years before a lung met shows up, are going to do better overall than those who have an early disease recurrence. That speaks a lot to the biology of the tumor and maybe not so much to the ability to resect. If you are going to resect, it doesn't seem to matter whether you have one met or more than one met, as long as they're all completely resectable, as seen as in this panel down in panel C. If you are able to completely resect all the tumors, the outcomes, look again, this is what I was telling you about before. We're not talking about 5, 10, or 100 or 15 months. This is 50, 100, 150 months. These are long-term outcomes. So 5, 10 years, 15 years out. If you've had a complete resection, you're going to do better than if you can't completely resect the tumor. So when we look at prognostic features, DFI greater than 36 months, more than double survival at 10 years. It doesn't matter whether you have single or multiple lesions, as long as you can get them all out, and a complete resection is strongly favored. Now, the patient I showed you that had tumor coming up against the lung, and I said I was concerned with tumors perforating through the lung. We operated on her yesterday. And what I found when I was in there, unfortunately, was that tumor has perforated through the lung and is starting to grow into the lung cavity or the chest cavity. And this is something that I cannot control surgically. So these are the areas that you can see, but you know that microscopically it's been able to invade through the cavity. So if we catch tumors before they're able to perforate through the lung or grow into surrounding structures like the heart, we have a much better chance of controlling that tumor and avoiding serious problems that will require more intensive therapy later on. So what now? What do we do with our patient who's got metastatic disease outside in the chest? Well, we can observe, because this is very slow growing. We can go in and do a bigger operation called a pleurectomy, which means that we remove the entire inside lining of the chest. It's a radical operation, but it's one that we can discuss. It may or may not improve our overall survival. We can discuss conventional chemotherapy, and then Dr. Ferraroto, I think, has either talked to you or will talk to you about the indication for targeted therapy or going on to clinical trials. So as a wrap up, we probably will never be able to do prospective trials looking at patients who are randomized between surgery versus chemotherapy or targeted therapy that amount to a reasonable trial. It takes hundreds of patients to be entered into those trials, and ACC is not that common of disease. Despite the fact that I've seen like 3 or 4 in the last week, they come in waves. It's logical that in the face of slow progression and limited metastatic disease that local therapy could control and preserve other therapies for another time as needed. And the analogy that I use with people coming into my clinic is that you have weeds growing in the rose garden. I know if I pull these weeds out, you may have other weeds in the future, but I don't want this weed to take over the roses. So if this weed is threatening some of the roses in the rose garden and it's a reasonable operation, let's get it taken out. Because if I take this out, it may keep you from having to have other different types of therapy. There are only so many weapons in your armamentarium of therapy. And if you use those weapons too early, they're not usable later on. And sometimes you can't go back to reusing them in the future. In other words, if you've got a hand grenade left in the chest and you throw it before you see the enemy's eyes, you haven't hit the enemy and you're going to be out of hand grenades when the enemy comes to get you. So to wrap up, and I would love to hear questions from the group if you would like, is I think that surgery is a reasonable option in selected patients. Patients do very well from the operation. And in the right situation, it can run into them disease-free for a number of years. Thanks very much.
Thank you, Dr. Hofstetter. That was excellent. You covered so many really important points. This is very, very helpful. If you don't mind, we have a couple of questions. First one would be, could you talk a little bit about if a patient were to proceed with lung met surgery, what sort of a typical post-surgery recovery time, and also what are the short and long-term quality of life issues? Certainly on radiation, we know there can be very short and long-term. My wife likes to say that radiation is the gift that keeps on giving. sadly, for over decades. Can you give a sense on surgery, what, short and long-term outlook for the toxicity?
So clearly it depends on how much of the lung parenchyma you have to remove. If you're just removing edges of the lung, like I showed you in the two patient examples, I'm not affecting lung function so much as to affect quality of life. So from the standpoint of quality of life, once you've recovered from the surgery, which is usually pretty quick, you have this confidence that you're not coming in to see the doctor with disease, and it sort of does give a little bit of a hope component to it. What is dangerous about that is that I don't think that I can use look, I don't see anything there, so therefore you've got nothing in your body. Once you have metastatic ACC, you're probably going to have other lesions show up in the future, but if they're slow enough growing, we'll deal with them as they pop up. Kind of a cherry picking technique. Patients are typically in the hospital between a day or 2 days. As long as the resections are very little lung, the quality of life is excellent. We typically don't remove an entire lung for metastatic ACC, but we have done that in the past when there were no better therapies and the tumor was threatening the heart or other parts of the body. I think within a month, one of my partners removed the entire left lung because an ACC met was threatening to invade into the heart. And the only way to avoid that was to actually remove the lung. We test to make sure that the lung function is okay before we do that. We know that people do fine on one lung. You've got 2 lungs, and you only really need about 40% of lung function to function well. So you do quite well. It's a bit like having the redundancy or the extra kidney. You can donate that kidney just like you can the lung. With minimally invasive techniques, people are, typically up and around and usually completely recovered within about 2 to 4 weeks. Open techniques, sometimes it's necessary to open the chest to get at these, especially if there's more than one lesion or if they're deep. People might take a couple months to recover, but you're up on the day of surgery and feeling pretty well.
Wonderful. Thank you. You discussed sort of the array of treatment options, radiation, systemic therapy, in addition to surgery. Can you talk a little bit about, I don't know whether you have interesting discussions during your tumor boards, your multidisciplinary committees. Can you talk about that process of talking to your oncology colleagues about which would be the best approach for an individual patient? And can you maybe talk about the border cases, the ones where you might actually have a disagreement with the radiation oncologist or a disagreement with the systemic, with the medical oncologist?
Who told you that doctors ever disagree? That's a myth. We probably don't talk about ACC in multi-disc conferences as much as you all would like, just because it's either a rare occurrence or the treatment is pretty straightforward. Dr. Ferrarotto is on the call currently or will be on the call?
Unfortunately not. She's at a conference.
Okay. So, we have specialists within the institution who really have, made it their academic pursuit to discover more about ACC, and I would consider Dr. Ferrarotto one of those doctors. So when there's a question about how a patient should be approached individually, because it seems like the extent of tumor is beyond what we can control with local control methods such as surgery or radiation, as I mentioned before. Then we start talking about, what can we do other than surgery? Because this tumor is slow growing, it's pretty typical that if you have just, 1 or 2 or a few lung mets, they will either be followed by the medical oncologist or referred to the surgeons. Oftentimes the surgeons wish the patients were referred earlier. You're not going to, there we go. We wish that they were referred earlier because in the situation that you saw from the patient I presented, we don't like to see tumor perforate through lung and grow into the chest. One could argue that the data shows that operating may not change the natural course of the disease. But in the situation that I showed you, if I had operated earlier, maybe I would have avoided perforation of the tumor and spread through the chest. And I'm pretty sure that in this patient, it would have changed the course of the disease. So, yeah, we talk about it multi-disc. We disagree in some situations. In situations where patients do not want or can't tolerate surgery, radiation is a decent option. The local control rates are pretty good, at least 60 to 80%. And it's a decent option to surgery. With ablation, the local control rates depend on size. And ablation has local control rates, again, about 60 to 80%. So in a surgical candidate, it's probably the easiest option. It's quite easy to do wedge resections and patients tolerate it well. But if you don't want surgery, it's either radiation or ablation.
Super, thank you. You mentioned the armamentarium. Can you talk a little about sequencing? Does surgery always have to happen before radiation? Can you ever do surgery after SBR treatment of a lung met?
Yeah, if there's failure after SBRT, we can consider surgery. It's not impossible. Sometimes it's hard to detect after SBRT when there's going to be a failure, because you may leave a scar after SBRT and you can't tell if you're dealing with scar or with tumor. So it may take years after SBRT to even recognize that you have a failure, which is fine, because then, there's remodeling of tissue, and if the tumor recurs, you could go in and operate later. I don't like operating after radiation. It's more difficult. It's harder to tell the difference between scar and tumor. And so if the tumor is not delineated well, I don't know if I'm cutting tumor or if I'm cutting scar. And so if I have to cut the whole area out, I end up cutting more lung out than I would have otherwise. But to answer your question, it is possible to operate after radiation. Sequencing in terms of operating, we can do multiple operations, meaning I can operate on the lung, and if something comes up 3 years later, I can operate on the lung again. If something comes up 3 years later, I can operate on that lung again. So, we've gone back 3, 4, and 5 times. It's a lot easier the first time, but with these minimally invasive techniques, the scarring isn't bad, and frequently it's not a big deal to go back and to reoperate. We operate around targeted and chemotherapy as needed. But I would say that typically, if you're requiring chemotherapy or targeted therapy, it usually means that you weren't a good candidate for surgery up front.
Okay, thank you. Last question. I think you touched on it. So if there's scar tissue after a surgery, how easy is it to tell from a CT scan whether that's there is recurrent tumor? Do you have to wait till it's much larger, or is it fairly straightforward to tell if there has been a recurrence after surgery?
Sometimes it is, and sometimes it isn't. The example that I showed you today, where I showed you the CT scan and then the pictures intraoperatively, I was worried that the tumor had perforated, but I couldn't see that the tumor had perforated until I actually put a scope in and saw it with my eyes. So, you often can't tell if you're dealing with scar tissue or tumor until you look. So in situations where you think that an exploration is reasonable, you may decide to explore and figure it out. But if it's obvious, you can tell sometimes on CT scan or PET scan whether you've got an obvious recurrence that's spread.
Mm-hmm. Super. That's great. So actually, I think we have a couple more minutes. Can I open it up to the patients here? If we have yes. Yeah. So the question was about residual tumor after radiation. I mentioned surgery, but yeah, this is actually after radiation. How difficult is it to tell whether there's residual tumor after radiation? Is that being able to distinguish between residual tumor, radiation scarring, I guess, or a new tumor? Is that a?
It can be difficult. Sometimes a PET scan can help. Sometimes time. If you're not sure if there's residual tumor, serial CT scans and change is what's important. I don't know if you saw the whole talk, but if you go and look at scans and you've got scans that are spanning yearly and you see change on those scans, wherever you see change is where you're going to focus. So if you've had SBRT and there's scar there and that scar is not changing, then that's something I wouldn't worry about. But if it's changing, growing, the morphology of that scar is changing, then it's something that we start pursuing. But you don't go to surgery first just because the scar is changing. We might do some diagnostic studies, maybe even doing a biopsy make sure it's there. It might be obvious on the PET scan, and then we could do something, without doing a biopsy. But if it's not obvious, especially with ACC, because it's slow growing, most of us tend to watch until we're sure that there is residual disease before recommending any kind of other local therapy.
Great, thank you. I have another question here. If the tumor is in the pleura, not the lungs, is surgery possible?
On a rare occasion, it is. So I mentioned in the patient that I showed you an example of, we can go and strip the entire pleura out. I can't tell you that I know what the benefit will be, but I can tell you that if I don't have any other way to control it, it's a consideration. We've done that on several patients, but an experience of several patients does not a study make. It's just an experience. So from a standpoint of experience, yes, we can do it. Can I tell you definitively that that's going to be helpful? No. But in a situation, if I don't have anything else to offer, the patient's molecular pathology isn't showing anything that we can, target, not responsive to other therapies, radiating the entire pleura is not really that effective. And we have considered doing surgery in that situation.
Yeah, go ahead. One more.
So I'll try to paraphrase. So if you've got multiple, scattered mets, and you take the approach of cherry picking through surgery, through SBRT, through microwave or RFA ablation, then can you get to a situation where you have no evident disease?
It's a frequent question, and it comes down to how many mets we're talking about. So I've seen people that have 5 mets in each lung that were all peripheral, and it's reasonable to come up with a strategy that we could go after all of them. On the other hand, if it's a 70-year-old patient and I've got slow-growing mets and they don't seem to be doing any damage, then I might be advocating for just watching. If you've got 20 lesions in each lung and they're all millimeters in size and they're spread throughout the lung, coming up with a treatment strategy where I operate on some, ablate others, and radiate on others, it's probably not going to change the prognosis. I'm going to do a lot of damage to the lungs. So in situations where I have defined small number of lesions in each lung, it's reasonable to go take them out and try to render someone disease-free. If I've got 10, 20, 30 mets in each lung, it's probably not reasonable, because by the time they finish recovering from the surgery, I've got other things growing, and I'm never going to render them disease-free, but I am going to give them the risk of local therapy. Does that make sense?
Yes. Yep.
If it makes sense to you, it might make sense to others. So nod like it doesn't make sense. Ask questions if it doesn't make sense. There is a risk to doing surgery, and if I can't get all the disease out, then it's not worth doing the surgery or any local therapy.
One more question. In the ACC patient community, we sort of in the social media, we often hear about brachytherapy and for lungs. Is that something that you think makes sense? How would you consider that relative to the microwave ablation or radiofrequency ablation? Or
did you say BRCA, BRCA?
I'm sorry. No, I apologize. Brachytherapy. The brachytherapy seeds. Yeah. Mm-hmm.
Yeah, I was afraid you were going to ask me something I didn't know about. So I'm a surgeon and not a radiation oncologist. I will tell you that brachytherapy in and of itself is not an option that I would consider, just because we don't have good track record with it, and there are other options that have better outcomes. So, there's multiple things that you can do that might control a tumor but not get rid of it, and I'm not sure that the risk is worth the reward. So a long run for a short slide.
Great. Right. Again, thank you so much for sharing your expertise. That was absolutely wonderful. Thank you very much.
My pleasure, Jeff. Thanks. Take care.